Hello, everyone. Welcome to Tuesday Night Rheumatology. This is a webinar, and this month is devoted to interstitial lung disease. And tonight we're going to be talking about the treatment of ILD and future treatment of ILD. I want to thank this campaign on ILD and the sponsor of it, which is Boehringer Ingelheim. There's a number of things that they've been most helpful with it in doing this. I want you to know that we're going to have Tuesday Night Rheumatology every Tuesday in the month of September going forward. Tonight is future treatment and treatment of ILD. Next week, controversies in ILD. We have Elena Yorns and Jeff Sparks and Janet Pope, and someone else is going to be joining us. The third week, we're going to have a journal club on two important seminal papers on ILD. And our last week, we're going to talk about diagnosis, screening, and monitoring. So that's every week going forward. I want to point you to the website, which has a ton of content, and specifically top right on the email, top right on the website is a therapeutic update where we have a series of videos, and the title of these videos is ILD Treatment and Guidelines. And you're going to find these really, really good. You can watch the videos as I was doing all day today, or you can listen to the podcast of those. That's coming up in the next few days, and it'll be on the website. So I'd like to begin by having our panelists introduce themselves. I'm the moderator, Jack Cush from Dallas, Texas. Dr. Johnson.
Hello, everyone. My name is Dr. Sindhu Johnson. I'm a rheumatologist at the University of Toronto, director of the Toronto Scleroderma Program, and director of the Clinical Epidemiology Program at the Dalla Lana School of Public Health.
Dr. Shapera.
Hi, everybody. My name's Dr. Shane Shapera, and I run the interstitial lung disease program as a pulmonologist at the University of Toronto, and I work closely with Dr. Johnson. I also work with our very large lung transplant program, providing assessments and guidance for patients with ILD who are headed towards lung transplant.
And Dr. Matson.
Thanks. I'm happy to be here. My name is Scott Matson. I'm a pulmonologist at the University of Kansas. I'm the director of our autoimmune interstitial lung disease clinic, and we have a translational research lab that's focused on the use of immunomodulation across forms of pulmonary fibrosis.
Okay. Dr. Matson's got a great video that's currently on Room Now that you want to look at. So we're going to actually go over the survey that we sent out this week. It was a one-day survey. We warned you about it on Sunday night. We sent it to you Monday morning. With one email, we got 191 responses from mostly rheumatologists. 90% were rheumatologists, 6% were advanced practice providers, and a smattering of pulmonologists, which I was delighted to see. I think it was like 2 or 3% in there, but this is mostly a rheumatologist response to these 10 questions about treatment. These rheumatologists were mostly in private practice, about 60%, less than a third are coming from academic medicine, and 7% are trainees and fellows. So let's get into what the questions were and where they are. And I want to remind the audience that please ask questions, okay? We want to hear your questions. We want to know what you think. If you ask questions while we're doing this program, we'll ask our panelists live at the same time that we're discussing any point that that's in play, so to speak. So our first question is, in your rheumatic patients who have ILD, and again, this is often called CT-ILD, better term SARD, systemic autoimmune rheumatic disease, associated ILD, in your patient, who usually treats the ILD? I must say I found this surprising, in that 2/3 of us are having co-management by rheumatology and pulmonary. 22% of you said I'm managing it. 11% said the pulmonologist is largely doing this. So we have rheumatologists and we have pulmonologists. What's your perspective on how these people are getting managed? Scott?
Yeah, I mean, I think this is a really interesting response, and I think it probably does speak a little bit to the audience that's responding here. I think what we know about the way ILD care is practiced across the world is that even if it's co-management, there's various different levels of co-management. At some of these academic centers, for instance, where we practice, we have an autoimmune lung disease clinic where a rheumatologist and I sit, elbow to elbow, see the same patient, make decisions in real time about what we're doing initially and how we're going to change those therapies. But that's a pretty small fraction of the patients that come to our center. And many of them are managed in a way that I think is probably more common, which is non-contiguous, non-simultaneous care, where, we may see someone write a note. Maybe if we're lucky, we can send a text message to the, sharing rheumatologist and talk about changes we're interested in making. But I do think it's one of the really interesting sort of aspects of caring for these people is it's a multidisciplinary care that should be driving most of these decisions. And how do you build that kind of shared practice when you're seeing patients and co-managing, not even across the same center, but often state to state or referrals that come in from community rheumatologist to an academic center or vice versa. So I think it's still probably even more diverse than what co-management looks like, because I think co-management can look like so many different models.
Shane, is it any different in Toronto?
Yeah, I think Scott's point about what part is shared is really interesting. I mean, to me, in my experience, the shared component is for a lot of my colleagues in the pulmonary community, their job is to interpret and make sense of the PFTs and the CT scan. But then what to do with that, a lot of my colleagues really struggle, right? I think when I finished my training in around 2010, mycophenolate was like, the new kid on the block. And a lot of my colleagues weren't comfortable using mycophenolate. I think a lot of the pulmonologists now are pretty comfortable using mycophenolate in scleroderma, but they're scared to do it because, they don't know things like that the mycophenolate isn't going to help with the joint disease in rheumatoid arthritis. That's the kind of thing we need our rheumatology colleagues. So I think a lot of my colleagues, they'll say their job is to interpret the PFT and the CT, and then they send a letter to say, hey, things are getting worse. You decide what we do next.
So, Sindhu, what happens when you get that letter or that referral?
Well, very rarely do I ever get a letter from Shane Shapera asking me what to do next. But I will say I'm thrilled to see the survey response that the vast majority of people are co-managing in some style, because that is what the ACR chest guidelines are calling for. Sure, rheumatologists are very comfortable with immunosuppressive drugs, especially the toxic ones like cyclophosphamide, and we're comfortable with managing the multisystem disease. But there are many other aspects of ILD care, like ambulatory desaturation testing, monitoring, referral for lung transplant. And these things are not within the scope of a rheumatologist practice, but where most pulmonologists would feel very comfortable.
Okay, that seems reasonable. Again, I think this certainly, if it isn't what people really do, it certainly should be what I think we should be doing, because we need, certainly the patient's going to benefit from the crosstalk, is it not? So when I asked the rheumatologist what determines which patient will be treated for ILD, and you could see that they're given choices of ILD severity that could be by PFTs or imaging, the presence of extrapulmonary manifestations, patient age. The vast majority chose all of these. And so I guess I want to know, is it different between pulmonary and rheumatology as to when you pull the trigger and say, I'm going to do more than, I'm going to treat the ILD specifically, whether that's with an immunosuppressant or an antifibrotic. Sindhu, what do you think?
I think who pulls the trigger depends on who the patient saw first. And so, if they get to rheumatology, we're often starting immunosuppressive therapy or moving to a biologic for the whole disease. Whereas if they see a pulmonologist first, then the pulmonologist will say this ILD needs to be treated or not treated.
Yeah. Shane, is it
Although
worried?
I'll tell you, in Canada, we're generally opposed to the concept of pulling the trigger in any circumstance. So I don't know if our patients love it if we talk about who's pulling the trigger. But I mean, I agree very much. I think all of these elements really come together, and I think it really depends on the path, right? We have a whole bunch of patients who I think have IPF, and then 3 years later they start to get some joint disease, and I've already got them on antifibrotics. They go to the rheumatologist who says, "Oh, well, now you've got synovitis," and they'll start them on something for their joints. But then the flip will be, we get a lot of patients that get referred to us from places like the scleroderma clinic, because the truth is particularly they'll send to us when they're looking for us to access antifibrotics, because it's not easy to get these drugs and there's different side effects monitoring. And so we might have different processes in place that make it more easier for us to access those drugs.
So let me show the next slide and then ask Shane this question. What's the value of, I think I'm missing something, but anyway, what's the value of immunosuppressants in ILD? I'm worried that rheumatologists, we often use immunosuppressants. That's our preferred drug because that's what we know. I worry that we may think we're controlling ILD and it's, either its onset or its progression by our action, and maybe not considering that we should be doing more or thinking more about ILD. So what's your impression based on the last question and some of this answer right here?
So, I mean, I think that the value of immunosuppression in general in ILD kind of depends on the patient and the clinical phenotype, right? Like I think I really want to look at every patient's scan. I sort of consider looking at the CT scan with my own eyes as part of my physical exam in the clinic. So every time you come in, even if the scan was done a year ago, I'm still going to look at that scan again because I want to get a sense of if this is an NSIP inflammatory pattern or really fibrotic pattern. In my fibrotic patients, I might say, the real role of mycophenolate is to stabilize or to slow down loss of lung function. But if I've got a really inflammatory patient with myositis who's got organizing pneumonia on their CT scan, I'll actually tell them I think drugs like mycophenolate and other immunosuppressants may actually make you better, but it's going to be slow unless we're going to use really toxic drugs like prednisone. So we got to be patient when we start these drugs.
Scott, I don't think I made my point last time that I maybe you can help me with. I think we think that if we're using immunosuppressants, we're treating the disease, and that's good enough in treating and forestalling the ILD. Is that true or not true?
Yeah, I mean, honestly, I think this is one of the most important questions we all face from a clinical and a research perspective in this field, especially in the fibrotic autoimmune interstitial lung disease population. I think immune suppression pretty clearly helps appropriate disease control, especially in like the RA population that I think about a lot. Appropriate DMARD use and appropriate disease severity scores on therapy certainly protects against the development of ILD. So that seems to be pretty clear. Targeting disease activity most of all is the sort of most appropriate, first guidepost in treating these systemic disease. And then obviously even in early onset interstitial lung disease, it appears that that's probably one of the most reasonable targets. If the joints are out of control or the extrapulmonary manifestations are out of control, treat that with immunomodulation. In terms of, is immunomodulation the most appropriate treatment for those patients that have autoimmune lung disease that's fibrotic? I think, like Shane said, I think there's a lot of concern and a lot of interest in especially the pulmonary community about what do you do about those patients that have a more fibrotic predominant pattern? And certainly the anti-fibrotic drugs are aptly named for the use in that population. But one of the things that we're interested in our group is, are there patients with autoimmune interstitial lung disease that have fibrotic disease that responds well to immunomodulation? And are there radiographic patterns that predict better response? Because I think a lot of people are operating under that sort of idea that some of these patterns are more inflammatory than others. And it's difficult to say. I mean, when we've looked at some post hoc data, all the pretreatment scans across the scleroderma lung studies 1 and 2, and we looked at quantitative measures of fibrosis in that population. And we assumed that the more fibrosis those patients had, the less FVC response they would have to immunosuppression. And interestingly, we actually see the opposite. The greater fibrosis score in those patient populations was associated with a better FVC response to cyclophosphamide when we pooled all those patients from the scleroderma lung study. And we saw the same thing in our RA-ILD cohorts. And so I think it does beg this question, which is, I think we don't know the answer. And I think until we get a randomized study that really looks at the role of these kinds of patterns in immunosuppression response, I think it very much remains to be seen whether or not there are some of these patients that still benefit, who have fibrotic interstitial lung disease, that have a greater benefit from this kind of strategy. I think there's a whole other discussion we'll probably have during the rest of this course about the role of antifibrotics in this population. But honestly, I think to me, this is one of the most interesting and important questions. And that's a lot about the efficacy. I think there's also a lot of very real and important concerns about the safety of adding these to those populations too, which those data just aren't positioned to help us answer.
Right. Sindhu, what do you think?
think there is a role. I mean, this is ILD, and in the setting of systemic autoimmune rheumatic disease, is complex. This is not a single mechanism problem. And so we've had great advances in the last 15 or 20 years with our randomized trials of both nintedanib and other immunosuppressives. But if we take lessons from rheumatoid arthritis, congestive heart failure, et cetera, we learn that it's combination therapy or combination targets that will really see leaps forward. So, I think right now we're in the mindset of immunosuppressive plus an so-called antifibrotic, so combination dual therapy in people that are progressing. And I think this is just the tip of the iceberg. And when we move to talking about the future, I think the real future will be multimodal therapy.
Okay. I have a question from the audience from Marilyn Solsky, and I'm going to direct this at Shane. And Shane, the question has to do with who should prescribe nintedanib, OVEF, a rheumatologist or pulmonologist. And the two sides to the coin is that, the doctor, obviously, who is treating the patient, but rheumatologists are reluctant to do so because they have no experience with it. And then the pulmonologists, I think, certainly have experience with it, but does that not end up with a lot of people being undertreated if one group is unwilling to do it? I mean, rheumatologists like Sindhu and others who are in the field, who are rheumatologists that are specializing or really interested in, they're writing for nintedanib, but should more have been. So what's the advice from pulmonary to rheumatology on starting that drug? Shane, what do you think?
Yeah, I think, I think it really just depends on the comfort of the prescriber, right? So, I have no problems with a rheumatologist starting antifibrotics on a shared patient. If they've got fibrotic lung disease, they're getting worse, and they say, yeah, they're more breathless. I see that their PFTs were getting worse, but their joints are inactive, and I'm going to go for it and start antifibrotic therapy. I'm on board. I think that is going to continue to be the minority of cases for the same reason why pulmonologists are a little hesitant to start rituximab. Like I start rituximab, but very few of my colleagues feel like they do it enough that they can counsel the patients appropriately, that they can deal with side effects appropriately. So I think the key is that if you're going to be a rheumatologist who starts antifibrotics, that's totally fine. But you got to do it enough that you really feel comfortable managing side effects, knowing what to monitor for, knowing when you give up, when do you lower the dose. You got to get critical mass.
Yeah, that's really helpful. And I think, honestly, I think most would rather refer, but I think this speaks to the importance of co-managing. Another question from Michael, do you think that true co-management side by side could lead um, both rooms and poems to get more comfortable with each other's therapies? So yeah, I think it would, because we have the example of room derm clinics where they're getting really comfortable managing each side of the fence, and room cardiology clinics, the same thing. I mean, the next step would be to have a combined pulmonary rheumatology clinic. Scott, you have a autoimmune interest in Kansas. Do you have a combined clinic, or should you?
Yeah, we do have a combined clinic. It's myself and a rheumatologist, and we see new consults as well as patients that we have shared or that people refer from within our setting. And I think you're right. I mean, I think it makes these decisions pretty easy in the sense that we can co-counsel the patient on, each other's sort of expected side effects, and it makes the discussion, especially for, as Dr. Johnson mentioned already, this multimodal therapy is likely the way many of these patients are managed now and will be managed in the future. And because it takes a while to develop that critical mass of experience with both of the medicines and monitoring the side effects simultaneously, I mean, I think it's great. I mean, it's also true that the patients really enjoy the one clinic visit as opposed to two for the management of their ILD. So that's, one of the major, I think, upsides. But certainly it's been, I've learned a lot having sat next to the rheumatologist and making these decisions.
All right, let me go on to the next question, and I got more questions from the audience. I did ask this question. I treat autoimmune disease and ILD because of high mortality, worse quality of life in 30%, better outcomes of newer agents. Sindhu, you want to address this, or is it pretty accurate in your opinion, as to what's the good reason to treat SARD ILD?
I mean, I think these are all great reasons to treat it. I think the one difficult conversation to have with the patients is that patients, they want to feel better, right? They want to stop coughing. They want to be able to laugh without coughing. They want to be able to work without coughing, or, they want to be able to work without their reduced exercise tolerance. But we, the treating physicians, are often focused on improving survival or preventing mortality. And so our objectives and the patient's objectives may not be the same. And so that, it sounds like Dr. Shapera already level sets in his clinic about being patient. But I think that being clear to the patient about what are our objectives and what, in contrast to what are their objectives, is an important conversation to have.
All right, so let me go on. This next issue is deals with well, what drugs do you most rely upon? I alluded to this earlier. Rheumatologists are heavily into immunosuppressants. And then if you look on the right, which one do you prefer to use? It's mostly mycophenolate in more than 3/4. And again, around 15% are using a biologic, either rituximab or IL-6. Very little use of azathioprine and cyclophosphamide and antipsychotics. And rheumatologists are using very little antifibrotics. That's like 5% or less in this top left graph, that green slice there, right there. So this is kind of saying what we already said, but I think the question that I have is, should we be using more azathioprine and cyclophosphamide given where it stands on the current guidelines, both from ERS, EULAR, and ACR and chest? Sindhu, what do you think?
So the whole azathioprine landing on our menu of options was one of the controversies that happened after the guidelines. And so, azathioprine is one of our traditional drugs for, physicians that were treating patients in the 80s and the 90s. It's inexpensive. The evidence for it is modest at best. And there is some observational data to suggest that it may do more harm than good. So lots of reasons for it to be controversial. But the reality, so point number 2 is guidelines are region specific. So the ATS, chest, ACR guidelines are really meant for North America, whereas the ERS guidelines are meant for Europe. And so cultures are different. Some sectors are put more emphasis on efficacy, less emphasis on toxicity. Whereas in North America, we tend to be risk averse. And so we don't like the toxicity of cyclophosphamide or the toxicity of steroids. So that brings me to the third and final point, is that we also have an increasing middle class, which we call the working poor. So people that are not rich enough to pay for their biologic, like tocilizumab or rituximab, but they don't have private health insurance either to pay for these drugs. So then what happens? And so it was for all of these reasons that azathioprine remained on the menu. And if you look at, when we get to the slide later about the menu of options, you'll see that azathioprine is quite low. We have better drugs that we all prefer, but what do you do if a patient is not tolerant to mycophenolate, can't take cyclophosphamide for fertility reasons, and can't afford a biologic? And so azathioprine is an option in those situations.
I'm going to put the 3 of you on the spot on about one drug in particular, and that's mycophenolate. The guidelines say that the starting dose of mycophenolate, I believe, is 1,500 BID. And can each of you give me a caveat or a pearl about the one thing that most people don't know about using mycophenolate in patients with ILD? Scott, do you have a pearl?
Yeah, it's a good question. We use a lot of mycophenolate in our clinic, and it is one of those drugs that I feel like, there's a lot of anecdote, but I feel like a lot of patients tolerate it very well without any major issues. But there are a few that we see pretty rarely. The ones that we probably see most commonly, and this is probably old news for most of the rheumatologists, but we see hair loss in some patients. We see a colitis in a small number of patients. And then probably the most common thing we see is a herpes zoster reaction, but this is probably fairly common across many of these drugs.
So if you have to, I'm going to ask Shane the same question, but also ask if you have to lower the dose, how low do you go before you switch to another drug? Shane.
To answer the first question, I think those are some good pearls. I think the two pearls that I would have added is just that out of all of our drugs in my older patients, I have to say I actually like mycophenolate. Like, you give someone who's 82 years old mycophenolate or an nintedanib, and I tell you which one they're going to tolerate better. So I think that when we talk about quality of life, that's an important thing to think about as well. One of the ways I've been burned earlier in my career, but still every once in a while, is this colitis that's got mentioned. These patients who come, they just don't feel well. They're losing weight. They're anemic. And you can't figure out what it is. They get scoped up and down, and then you stop their mycophenolate for a month, and they're like magically cured. So those are sort of my two pearls. And sorry, Jack, what was the main question you asked me that I politician like didn't really answer?
You should be running for office. No, if you have to lower the dose, well, is
Oh,
2,000 good enough? Well,
yeah.
or will you
I'm
bail below 2,000?
Yeah, in fact, I'm actually pretty comfortable with mycophenolate mofetil using 1 gram twice a day. I think that's probably a pretty established and reasonable dose. And we also use a lot of mycophenolate sodium, and I'll use 720 BID in that cohort. I think that's a reasonable dose. Once I start getting down to people who can only tolerate 500 twice a day or 750 twice a day, if they have mild disease that isn't progressing much, I'll take it. But if that's as high as I can go, that's when we start saying, hey, well, if you're getting worse, maybe we should be thinking about either switching to azathioprine for all the reasons Sindhu mentioned, or potentially switching or adding rituximab. In fact, with the lower dose, adding rituximab might be a pretty reasonable thing if they're getting worse. I don't know, Sindhu, what about you? What's your lowest dose that you'll take?
How low?
How
One
low will you
tab
go?
BID. So either 500 BID or 360 BID.
I'll remind everyone the greatest teratogen that we use in rheumatology is not cyclophosphamide, it's mycophenolate. So luckily, this population isn't enriched for women of childbearing potential, but it's a significant worry nonetheless. So our next question has to do with antifibrotics. So I want to ask our panel, are the drugs, specifically nintedanib, pirfenidone, and others in development, are they really antifibrotic given their mechanism of action? Tocilizumab is an IL-6 inhibitor. It's going to treat inflammation, which will help blood flow, which will maybe be anti-fibrotic by helping blood flow. Nintedanib is a tyrosine kinase, and don't ask me what pirfenidone is. My professor of pharmacology invented pirfenidone and was after me for years, trying to tell me it did all kinds of things. So, but knowing what you know about these drugs, are they really anti-fibrotic? Who wants to take a stab at that?
I can jump in. I think we should think of these more as fibrostatic rather than antifibrotic. I mean, I think really, and that's helpful when we're educating our patients about them too, right? Like I'll be honest, I'm not entirely sure about the antifibrotic properties of hydroxychloroquine, so I won't comment. But like when we're talking about nintedanib specifically, when patients hear antifibrotic, like they think antibiotics that kills all the bacteria and it cures the problem. And I think it's important that we kind of use the term antifibrotic and then immediately say it's not actually antifibrotic, it's more fibrostatic. We're hoping that it'll slow down progression, interfere with how your body makes new scar tissue so it does it more slowly. So that's where I land. And I'm interested to see that pirfenidone only got 8.1% because I have to say, like, there's no doubt Nintedanib has better data. But if you really delve down deep into the relief trial and into some of the other studies in non-IPF fibrotic ILD, pirfenidone almost certainly also has a pretty established role of being antifibrotic if you can get it. Problem is you can't get it because no one will pay for it.
Right, right. Um, and then we asked, what's their value of the antifibrotics, but I also threw in the IL-6. And rheumatologists said 60% it stabilizes and flattens FVC, which I believe to be the right answer. But 18% were unsure, and 15% said it improves FVC. So what's the truth on these drugs, Scott?
Yeah, I mean, I really think Shane really did a great job of the way that I try to also counsel my patients. if you look at every study of any of the antifibrotic drugs, and I'll just limit this to pirfenidone and nintedanib for now, what we know is that they get worse. Patients on those therapies have a decline in their forced vital capacity over the period of the trial. And it's not as significant of a decline as seen in the placebo group, but they start at a level like 72, and at the end of the trial, invariably, it will be below that. Both groups get worse. It's just that the treatment group doesn't get as bad as the placebo groups. So even though 59% here say stabilize and flatten, I mean, that's kind of the way I try to counsel it to patients. Really, I think that's the best case scenario. In most cases, what's actually happening is that they're getting worse, but they're not getting as bad as that counterfactual version of themselves that's not on the therapy. And that, I think, is really difficult from a clinical standpoint, because you start somebody on the therapy and they come back invariably worse. And what you have to sort of say is, this is what we expect. And honestly, this is the nature of this drug itself. And unfortunately, the era of these antifibrotic drugs, there's never been a single randomized study that's shown that they improve survival over the 52-week period. And with the exception of one post hoc analysis of the in-build data, which we could talk about in depth, but there's also never been a study of an antibiotic drug in the apparent RCT that showed a clinically meaningful benefit in health-related quality of life. So these are drugs that have a role, and they certainly slow down progression. But unfortunately, for most people, they will never feel as good as the day you start it. And often because of the side effect burden, this is the thing that's really difficult to balance, is that they will typically feel worse on those drugs, in addition to the financial toxicity that was already mentioned.
So, Sindhu, what's the upside?
Well, what's the upside is we're slowing down progression. So, but I think we have to be really realistic. Like, that I'm glad we had the census trial. I was an investigator on the census trial. And so that was a step forward. But, I remain optimistic that the next 5 years, we're going to have bigger steps forward.
Yeah.
And I feel like I came out pessimistic, but I use the drugs all the time, and largely because I think most people have survival expected to be longer than 52 weeks. And I think it's reasonable to say that if you have a preservation of FVC at a year, and that you multiply that by 2 years and 3 years, there probably are clinical survival, quality of life benefits to be had in that population longer than a year. I just think it's important also to be honest about the nature of the actual data for what we know over that short time period of a year in this population.
So how do you translate the expectation of flattening the FVC to the patient and their expectations when they're having, dyspnea on exertion, a real limitation to how far they can walk and what they can do? How do you set that up for an expectation with the patient? I don't think we rheumatologists really know how to address that.
Oh, that's too bad, because I usually mostly just tell them to go and talk to their rheumatologist about it.
Oops.
I thought you guys had all the answers.
Well, I can talk a lot about their underlying disease, whether it's myositis or Sjogren's or RA or scleroderma. But again, how it translates to their day-to-day life, they're going to want to do whatever they can to retain their function. So that's a big motivator right there.
Yeah, and Jack, I joke, but like the truth is, like I agree with Scott, and I know Sindhu was sort of saying the same. Like these drugs clearly do work, and I think I am very comfortable saying to my patients that delaying progression is a really meaningful thing. Like in our IPF cohort, like we've been using this in IPF for a lot longer, and like when I started and we first got these drugs in 2014, 2015. Like it's true that patients were gone. They didn't come back to my clinic after 3, 4, 5 years. And now I've still got some folks who've been on drug for 8, 9 years and who are getting worse, but pretty slow. So, I mean, I try and convey that it does work, but this is part of the counseling is that particularly with antifibrotics, we need to think about starting these drugs sooner rather than later. And I'm not suggesting that like everyone who comes into my door on day one gets started on an antifibrotic, but the worst thing we can do is wait until your quality of life is really impaired and then start you on a drug that's going to slow it down from there, right? That's not the right answer. We need to kind of get in there at that sweet spot where, you're clearly getting a little worse, but it's before this is really having a major impact on your quality of life so that we can slow it down from that point as much as possible.
So I want to get into the guidelines. Today on Room Now, we published that just came out, the European guidelines, two different publications from the ERS and EULAR, that was led by Anna Maria Volk-Hoffman, who was supposed to be here but couldn't be here this evening. And anyway, I asked the question of the audience, what guidelines are you familiar with or do you refer to in treating SARDS, that's systemic autoimmune rheumatic disease associated ILD? And majority were familiar with the ACR chest guidelines from 2023. Dr. Johnson was the lead author on that. 22% were familiar with the recent ERS EULAR guidelines just presented at Barcelona in June and published just last Friday. It was published. A few people are familiar with versions of the ATS guidelines from 2024, not 2025, but nonetheless, that's what they're what we say we're familiar with. But are you really? So let's go into these guidelines and see what they say. So here, led by Dr. Johnson, and published in ANR and ACNR, the 2023 ACR and College of the Chest Guideline for treatment of SARS-associated ILD. I'll make two statements and then let Dr. Johnson, the author, talk about I like that they divided it up by the most common diseases: sclerodermomyositis, MCTD, RA, and Sjogren's. And they give you first-line therapy and whether or not you should be using steroids. All of these are conditional, meaning we don't have, at the time that we did this, we didn't have great evidence for anything. And I put in bold the drugs that stand out in certain situations, because otherwise mycophenolate, azathioprine, cyclophosphamide seems to appear on all the lists, either as first line or third line. And then steroids are okay in all of them except for systemic sclerosis. So those are the things that stand out for me, a prescriber, rheumatologist who sees these patients. Sindhu, what more would you like to impart on the audience about these guidelines?
Well, thank you for the opportunity to explain this a little bit, and I'll try to address some of your comments. So first and foremost, this was a collaboration with the ACR and CHEST. There was a large number of rheumatologists and pulmonologists involved, including Dr. Matson. He's an author on this guideline as well. So things to be proud of, right? We've covered the five biggest diseases in rheumatology that have ILD as a major cause of morbidity and mortality. It did include a review of the literature, so all the major observational studies and clinical trials available at that time. But we also had the largest patient panel of any guideline in the world in rheumatology. And so why is that important? So, okay, I'm going to take a second just to step back. If you were practicing medicine in the 1980s and 90s, first of all, ILD was diagnosed on chest x-ray. And we often had to wait for patients to have symptoms, or you had to hear crepitations. So these patients were already far advanced by the time they got diagnosed. And in the last 10 or 15 years, we've had clinical trials that you've highlighted the drugs of in this picture. So that is a big leap forward. But Jack, you mentioned they're all conditional recommendations. Why conditional? Well, that has to do with the certainty of evidence. So clinical trials have better certainty evidence than observational studies. But the major problem we suffer from in the whole of rheumatology is small sample sizes. Almost all of our clinical trials have hundreds of patients. Janet Pope's methotrexate trial had 35 patients per arm. Whereas if you look at cardiology and the statin trials or the congestive heart failure trials, they have tens of thousands of patients per arm. So just because, by virtue of our sample sizes, that reduces the certainty of our evidence. And then the second piece is our primary outcome. Doctors love FVC as our primary outcome. But if you ask patients or the FDA, what outcomes do they care about? It's survival, feeling better, or functioning better. And so again, because we doctors do not include a primary outcome that matters to patients or the FDA, that reduces the certainty of evidence. So right off the bat, all our recommendations at best will be conditional because there are other factors we need to take into consideration. If we had a clinical question that had 5 amazing clinical trials, who needs a guideline? Anybody who reads the 5 clinical trials will know what the answer is. But in a setting of some evidence that's uncertain and 2 major organizations that have the resources to bring experts from all over North America together, we now have everybody's opinion on the evidence. But the final point that I'll make about this is that in a situation where you have low certainty evidence informing guidelines, these guidelines in particular are sensitive to patients' preferences and values. And so it's that the therapeutic relationship is important. You really need to know the patient in front of you, because whether you'll counsel them on cyclophosphamide may be very different than whether you'll counsel them on rituximab or tocilizumab. And so that's why I said it was so great that we had so many patients informing the guidelines, and why things like cyclophosphamide that most doctors are afraid of because of fertility, the patients said, we want that on the menu. Even if I'm 22 years old and may never have a child again, I want to know what my options are. So that addresses some of your points. But just to explain this graphic, for every disease, there's a menu of options. You do not have to prescribe in this order. It is just a menu. And so your choice of option may be influenced by comorbidities or extrapulmonary manifestations.
I think that the plus for the prescriber was that it was good to have options other than cyclophosphamide to go to first and second, and I think that's a real plus. You know, and it's good to see that the clinical trials in tocilizumab show up on the list for systemic sclerosis and as an option for MCTD. But then, and then we saw the beginning of nintedanib showing up also here. It goes further when we look at more recent guidelines that were just published today. Anybody want to take make a comment about this before we move on to the recent EULAR guidelines? Scott?
Yeah, I mean, I think just to further sort of bolster what Sindhu has mentioned before about the azathioprine in this guideline, I mean, I think one of the things I really appreciate about it is just the pragmatic nature of many of the recommendations on this green box. I mean, azathioprine, I think a lot of people in the rheumatology community are reasonably concerned about its use, especially in conditions like rheumatoid arthritis, where we have some obviously RCT level data for similar conditions like IPF of its harm. But I think it's reasonable to say that what the evidence we have in RA-ILD is pretty minimal, and there's observational data that we've looked across, you know, ILD centers for what's most commonly used, and azathioprine is still the most commonly used drug prior to 2021. So even though there are many newer options that have, you know, other observational data, I think it's still true that in the community, drugs like that are being used a lot in these populations. And for that reason, I think it was totally reasonable and pragmatic to include them in this guideline.
Sindhu, did you at all address in your guideline the use of combined therapy? It seems to me that as bad as the prognosis is for these patients, and as conditional as the data is, why isn't there a much more liberal use of combination or push towards combination?
So there was extensive discussion at the voting panel around combination therapy, and the feeling was for first ILD therapy, monotherapy was the strategy, because many patients will stabilize or not progress with monotherapy alone. However, I don't know if you have a slide for what do you do if a patient progresses, and that's where combination therapy has a role. Before you leave this slide, though, the 2 classes of drugs that we've not really spoken about this evening, but I'd like to draw your attention is in the panel for myositis-associated ILD. You've highlighted JAK inhibitors, and there's also calcineurin inhibitors, so tacrolimus, right? So tacrolimus and tofacitinib. For many pulmonologists and rheumatologists, the idea of using these 2 classes of medications for the treatment of ILD may be new.
And importantly, please correct me if I'm wrong, because I'm just a country rheumatologist, but the data in myositis is way better than in all the other conditions where you can actually have a turnaround. You can actually have improvement. Is that right, or have I been misled?
I think we would still call it low certainty evidence. We don't have large randomized trials, but you know, I think myositis ILD is a different beast than ILD and systemic sclerosis or even rheumatoid arthritis.
Yeah, I like that. I like that a lot.
And even I might just add that even within the myositis cohort, they are like different animals within the genus, you know, like you take an MDA5 patient and you compare that to a Joe 1, and they're just like they're as unrelated to how they're going to behave clinically, how they're going to respond to immunosuppressive therapy as a scleroderma is to you know, a rheumatoid patient. They are completely different entities, all kind of lumped together. And so I think that's really the myositis cohort here is the really complicated one, and I think it's a great one to kind of delve into if anyone wants to really sink their teeth into one of these diseases. It's the myositis, and thinking of the different subtypes and the different you know, combinations and how you treat. And there's a really lovely table that is that everyone, you know, as a reader of these guidelines, the rapidly progressive ILD, which is a completely different entity, but tends to be that myositis cohort where you really want to think about these drugs, the calcineurin inhibitors and other potential combination therapies.
So now we're going to get to the ERS EULAR guidelines published in Annals of Rheumatic Disease. And I'm just going to throw out a bunch of things to start with, that there are general recommendations and there are treatment recommendations. I think on the general side, the issue had to do with screening. And the main issue was everybody should be screened, is what they said, except for RA and Sjogren's patients that you should screen if they have risk factors. And the risk factors are age, male, smoking, seropositivity, inflammatory markers, and disease activity as risk factors. And maybe you could say the same thing for myositis, that that if they have risk factors, antisynthetase syndrome, et cetera, that they also need to be screened. That the screening tool is high-res CT. Nobody should do bronchoalveolar lavage unless you're concerned about infection. And here are the general evaluations that you should do at the start and repeatedly. And then there's this laundry list of treatment things that the things that stood out to me is that there are specific rules for pirfenidone use. There are specific rules for nintedanib use. And you know, and a lot of it has to do with fibrosis, and a lot of it has to do with going more aggressive. Who wants to give us their takeaways? The audience can read these bullets on treatment because it tries to address them by RA, by scleroderma associated, and then other CTD ILDs. But do each of you have a favorite point that you want to stress with the audience? Shane, do you want to take a stab at this?
Oh yeah, I got a favorite. So my definite favorite from the EULAR versus the really amazing publication by my colleagues on the panel from ACR. But the thing that I was really happy to see in EULAR is the idea of using CT scan for screening. The the ACR chest guidelines talk about screening with CT scan and pulmonary function testing. And, you know, I always really struggled with that for a couple reasons. The first is that when we're doing screening, we have to remember the goal of a screening test is to rule out disease. And essentially, I would argue that a high quality, high resolution CT scan with prone images that's done with a good protocol that doesn't show any ILD has essentially near a 99% ability to rule out disease. And so the idea that you're then going to do PFTs on top of the CT scan to screen for or rule out disease didn't entirely make sense to me. So that's something I think makes a lot more sense and is probably quite practical that we use PFTs. Don't get me wrong. I love PFTs. I do them all the time in people who I now know have ILD. But for screening and I just want to rule out disease, I would use HRCT and I'd pass it on to Scott. What do you think about that difference? And do you think, are you in agreement with me or do you still think there's a role for PFTs in screening for ILD?
You know, I think that's a really good point. You know, I guess I don't want to get on my own. I don't want to get on my particular soapbox, but I'm always a little bit worried about recommendations to screen for a condition that lacks a lot of high quality randomized prospective data in the actual clinical disease state. And so there are some of these conditions I worry a little bit about screening in general, regardless of the etiology that we screen for, just because I think we still are, as a pulmonologist and as somebody who thinks a lot about like fibrotic RA, for instance, I worry still about the lack of any prospective randomized data to support the safety of even the first line conditionally recommended therapies. I think it's the appropriate first line recommended therapy, but it's true still that there's potentially harm from some of those strategies, right? And we know that from similar fibrotic ILDs. And so one of my global concerns in general is I share, I think, everybody's hope and desire and belief truly that the only way to bend the natural history of ILD is to identify it earlier and treat it earlier. But I do worry about screening for a condition and then having downstream treatments change as a result of that screening in the absence of some of the clinical data that we still desperately need in the actual clinical disease state. But to speak to Shane's point, I think that's a really great point. I think probably a CT that excludes ILD, there's probably very little added benefit to a PFT at that point. But
so these guidelines were very liberal about the use of immunosuppressants to control the underlying disease as is necessary, but then they like to say that when the disease was severe or progressive, they like combinations of drugs, either combining immunosuppressants or combining nintedanib with a immunosuppressive. But so it seemed like nintedanib shows up as a recommendation when there's more and more fibrosis, or PPF is, you guys are great for acronyms that drive us crazy. Progressive pulmonary fibrosis. So what's the rule on nintedanib? When should we be, itchy to start that?
I think it's hard for us to answer the question because none of us were on that guideline.
Yeah. And again, the author of that was going to be here, but that didn't happen. But
do you think? I wonder, like Shane, do you think that, and Sindhu, do you guys think maybe that? I mean, this is, I think, one of the difficulties of guidelines is you have to use, the evidence, right, which is appropriate. But I think, like to Shane's point earlier, pirfenidone has been studied in RA, and in every other case where it's been studied, it has almost an identical effect and slightly different adverse effect profile, but generally in similar impact on disease trajectory. And they lack randomized controlled trials as large as nintedanib, but it does feel a little bit strange clinically when I use them 100% interchangeably and use patient factors about finances and adverse effects to choose. And then the guideline says use nintedanib, when really probably I think that they are fundamentally interchangeable. That's the way I think about it, but I don't know what you guys think.
Well, in grading guidelines, you win with a clinical trial, especially.
Yeah, totally, 100%. And you should. I'm just saying it's like,
immediately on top of the list. But yeah, it's a problem.
Yeah, I think it's important. I don't think the only thing I'll disagree with Scott there is that I don't think that they're exactly the same. I suspect that their targets might be a little bit different, and we just don't know because no one knows how pirfenidone actually works. But I totally agree. I mean, every once in a while, a patient will come to me who has ILD that's in a UIP pattern. It was previously thought to be IPF. They were tried on nintedanib. They couldn't tolerate it at all. They come to me and they have progressive pulmonary fibrosis, or PPF. It's really quite fibrotic, but they kind of have some aches and pains and their CCP is a little bit positive. And to be honest, what I'll often do is I'll put them on pirfenidone because at that point they have a diagnosis of IPF. At the same time as I refer them to rheumatology and let them sort of figure out what's going on with the joints. Because I mean, we were part of the trail study at our center, and I totally agree with Scott. They didn't meet their primary endpoint, there's a lot of challenges there. But to be honest, there is a very consistent signal that's probably just as good as the mycophenolate signal in scleroderma, that it never worked. It wasn't a positive trial, and yet it's a consistent signal across multiple studies that pirfenidone also slows progression of fibrotic non-IPF ILD.
So we also said that we were going to talk about future treatment in going forward, but we really haven't done much on that. And yet there have been some recent reports and very encouraging things. Shane, do you want to start and say what are you most excited about for the future here?
Yeah, I think in my world, for sure, the most exciting thing that's coming in the not too distant future actually is going to be nerandomilast, which is another drug made by Boehringer, the same company that makes nintedanib. And the nerandomilast was looked at in a phase 2 trial that showed some promise. And then more recently at the ATS this year in San Francisco, they announced that nerandomilast hit all its primary endpoints in both IPF and non-IPF ILD, or what we're now calling PPF. And nerandomilast not only did it seem to work as monotherapy, but could also be combined with nintedanib in as combination therapy on the fibrostatic or antifibrotic side of things. So I think this is going to be a really exciting new option for treatments. And for me, the thing that is probably most exciting about it is not its efficacy. Its efficacy was fine, but what seems really exciting is its safety profile and its toxicity. I mean, we'll see what happens in the real world, but in a clinical trial population, the side effect profile of nerandomilast, which still causes diarrhea like nintedanib, but the side effect profile was profoundly better with a much, much lower rate of discontinuation of the drug because of diarrhea, which is generally the main reason we stop the drug. So that's going to be coming to both Canada and the US, presumably in 2026. That's what we're hoping for. So it's not too far away before we might have a new drug available in our arsenal.
Sindhu, do you have any other suggestions for the future?
Sure. Well, I mean, it's not suggestions, but I can tell you what the future will be in the next 5 years. So first of all, I think we're done with carpet bombing the immune system. No more cyclophosphamide, mycophenolate, azathioprine, things that just suppress everything. I think we're going to move more and more to targeted immunosuppressive therapy. So drug to watch for number one is anifrolumab. So immunosuppressives that are already in the market for other diseases. It's in a clinical trial right now for scleroderma-associated ILD. So keep your eye out for Sefnello. The other group of medications to watch out for are the small molecules. There are a number of small molecules under study in phase 2 and 3 clinical trials right now. For example, one is an agonist of melanocortin-1 receptor. So wouldn't that be great if we now have an oral immunosuppressive therapy that's not injectable? The third is other monoclonal antibodies. The TNF-like cytokine 1A is in the pipeline. That clinical trial is closed. So in the next year or two, we should expect to see results. And then finally, what I actually believe is our future is going to be immunosuppressive therapies like monoclonal antibodies, but then hit 2 targets instead of 1 target. We already see that in oncology, and that's what's improved survival dramatically in areas like breast cancer. And there is a phase 2 clinical trial for scleroderma ILD that'll be a monoclonal antibody with 2 targets. And as I said earlier, I think combination therapy is really where we're going to see the next major leap forward for the management of ILD.
So I only have 2 minutes left. I want to ask this one question, if someone can answer it. How does a rheumatologist identify the trajectory that we're worried about, the rapidly progressive patient? Can you do that based on 2 FVCs done 3 months apart? Or do you need more than that? And what are we looking at? Because those are obviously 30% of patients who have ILD may not ever progress. It's the ones that are going to progress rapidly are the ones who end up in transplant or death or hospitalization. So how do we identify them?
Yeah, I mean, I think for those patients who are truly that very worrisome RP-ILD phenotype, 3 months is plenty of time, and that much FVC change. I mean, generally, this is a very non-subtle condition. I mean, many of these are slowly progressive, and I think the ones we're worried about are those that survival is measured in the count on the matter of months. And so, in general, most of those patients that come in this kind of phenotype, I think 3 months is honestly probably a little too long for some of the follow-up that's required to manage some of these patients. So I think, yes, certainly that the symptoms are usually the most important and most guiding principle for those patients. They are not subtle. They're needing a lot of oxygen rapidly. Is generally what I've seen. So I think definitely 2 FVCs should be plenty to identify that phenotype.
And lastly, rheumatologists are very concerned about the negative opinion that you cannot use methotrexate in patients who have UIP ILD or NSIP ILD. That you're not supposed to use it. We can't use it with hypersensitivity pneumonitis. That makes sense. But can you provide any clarity on what we should be doing there? It's a very controversial issue.
Yeah, it's a tough one, and I'll be willing to stick my neck out, and then Sindhu can cut it off if she wants. So no one knows the answer, and I think that's why it's like the perennial question. But I will say, now that I've been doing this for a bit, more and more, I feel like it seems to me like methotrexate causes an acute granulomatous pneumonitis. Rarely it happens. It's been well documented. It's going to happen early on after you start the drug. And that's not really the stuff we're talking about here. What we're talking about is a patient with rheumatoid arthritis, is the methotrexate what's causing the ILD? And I have to say, the more and more I do this, the more patients I see, the more papers I read. I'm not convinced that methotrexate causes ILD. In fact, there are lots of studies that show that being on methotrexate is protective in RA because it controls the underlying inflammation and the underlying disease. But what I do think is that there's a reason why I didn't make it into those fantastic ACR chest guidelines that my panelists wrote. Really just don't have any good data that it treats the ILD. So in my mind, if you're on methotrexate and we find that you have a little bit of interstitial changes, I don't think we need to like stop that drug and make you suffer with joint pains terribly. I think we should be monitoring you over time. And if we see that your ILD is progressing, then we say, okay, well, this drug just isn't working for all the aspects of your disease. And so now it's time to stop this one and find another drug that'll work both for your joints and your lungs. And that's sort of how my paradigm has evolved over the last 15 years.
All
Would
right.
other Sindhu, I gave you the option now to completely disagree with me. Go for it.
Oh gosh, no. After I never want to follow after the eloquent Dr. Shapera. He's right 100% of the time.
Well, I think it's a good point to end. I want to thank our panel for a really great discussion, really informative. I want to encourage the audience to return here next Tuesday night, where we're going to discuss controversies in ILD. And I want to thank again the sponsor, Boehringer Ingelheim, for helping out in this effort. Have a good night, everyone.
Good night.